It's a privilege and pleasure to introduce Dr. Leo Rotello, our grand round speaker today. He's an assistant professor of medicine at Johns Hopkins School of Medicine, Department of Critical Care and Pulmonary Medicine at the Armstrong Institute. And he's director of critical care medicine for Johns Hopkins Community Physicians and section chief for hospital-based medicine for Johns Hopkins Community Physicians, and section chief and medical director of the medical and surgical intensive care unit at Suburban Hospital, and also attending physician in the Department of Critical Care Medicine at the NIH. He specializes in medical, surgical, trauma, cardiovascular, critical care. He co-chairs the Armstrong Institute for Patient Safety and Quality, and has received honors and awards for clinical excellence, clinical collaboration, and teamwork. Dr. Rotello completed his critical care training at SUNY Upstate in Syracuse, New York, with Michael Jastrzemski, who, for those of you that are from EM, Dr. Jastrzemski is an EM physician. And Leo served there as associate professor, department chairman, and fellowship director at the Department of Critical Care. Dr. Rotello has authored many publications throughout his career, from sepsis and ARDS to blood management, critical care costs, and a gentle approach to removing cockroaches from the auditory canal with a suction device. His present area of interest focuses on ICU program development and management, which he's lectured on at local and national levels. Dr. Rotello is the chair of the Intensivist and Practice Committee of the Society of Critical Care Medicine and chair of the Internal Medicine Section Steering Committee of the SCCM. And finally, as it relates to his talk today, Anatomy and Physiology of a New Attending Intensivist Contract, which would be a real treat for our fellows. Since moving to Maryland and joining Johns Hopkins in 2009 after Syracuse, he's developed multiple critical care programs in the area and working with former SCCM President Tom Rainey. So without further ado, Leo Rotello talking about anatomy and physiology of a new attending intensivist contract. Thank you, Leo.
Thanks, John. Hi, everybody. I'm going to share my screen. Let me go into presentation mode. Can you guys see that okay? This is going to be pretty informal, so I can't see all the tiles that are on the side. So if you have a comment or question, just call out or just chime in, and we'll get to it. So I'm going to talk to you all today. What I do now, my interest now is more in the business of medicine. I'm still clinically practicing, but I wind up running 12 different programs, hospitalist critical care programs for Hopkins and their community division. So I do a lot of hiring and staffing. I hire about 270 physicians. So one thing that none of us got in our training was any insight into what it means to have a contract and how do you get a new job. And what are the questions you should be asking? So I put this together based on my experience, both personally and in my job, to kind of give fellows, residents, an idea of what to expect and how to approach getting a new job, getting your first job for most of you. So with that, we'll just jump right into it. So what do you need to know about contracts? So basically, you need to be able to understand and prioritize the components of your contract. You need to be able to have a knowledgeable discussion with your new employer. And if you're using one, you need to be able to have a knowledgeable discussion with your contract lawyer. This is not meant to make you guys contract lawyers. It's just meant to highlight what you should be thinking about when you're starting to interview and talking with people about jobs. The bad news is most physicians and NPs just out of training have never held a full-time job. You know, we've gone through college, we've gone through medical school, residency, fellowship, and we really, whereas a lot of our friends our own ages have had multiple jobs by that time. This is usually the first kind of real job at a training that any of us are going to have. So very few of us have ever really negotiated for a job or a contract. Most physicians just out of training really interview with a resident mindset. And by that, I mean, as residents and fellows, when you're trying to get into a program, you're just, thank God they took me. And you don't really ask a lot of questions, make a lot of demands. So when we kind of carry that along with us. So as we get out of training and into attending and whatnot, we really have to be able to change our mindset. And really, it's that you become the in-demand product. Not only do you want to impress your employers, but your employers are trying to impress you. They want you. If they interviewing you, it means they want you. For the most part, unless you kind of interview like an axe murderer or something like that. But for the most part, they're interested in you. They're trying to impress you as well. So it's a two-way street. We always try the interview process for the employer as well as the employee is just a painful process. It takes a lot of time. It's a lot of effort, bringing in new people. When I bring somebody in new, I want to make sure that I'm bringing in the right person, because I don't want that person turning around and leaving in a year. It is a disruption to the program. It costs a lot of money. So when I'm interviewing somebody, I've already done my groundwork to say that, hey, this is somebody that I think would be a good fit here. Now let's kind of just see if they are. So most contracts, what you need to do, most contracts are very fairly written. But there are some things within each contract that allow that there are some negotiation points. So most of them are pretty good. You're going to come across very few outright bad contracts, although there'll be a few. You want to keep in mind the desired end result when you're reviewing and negotiating. You pick a hill to die on. If you really want the job, then you negotiate. Then you're going to figure out what's really the most important thing for me to get out of these negotiations. I really like this job. So I'm really trying to get here. If it's a job that's okay, then you can be a little bit more forceful and say, you got to meet these things and then I'll come. So keep the big picture in mind ahead of time. Really think about what are the things you really need. There we go. So first we need to understand a little bit what kind of ICU practice models are out there, what are the pros and cons of each model, and what components should you look for. If you're going, and what I'm talking about works both for academics or community hospitals, but a lot of you will be, the most common critical care service in the country exists in a 200 to 300 bed community hospital. That's 80% of the critical care units out there. So if you're out there, so if you're leaving academics, then that's probably what you're going to wind up being in for the most part. Outside of academics, the closed concept really doesn't exist. When you get into community hospitals, there are already referral patterns and things like that. The attendings want to stay involved in their patients. So that idea of a closed unit, when I interview people coming out of fellowship, a lot of them ask about a closed unit. So for the most part, the unit, if you do a good job, the unit tends to close itself. None of the units that I put in are closed units, but all of them function as a closed unit because we're there. We're there 24/7. We're there, you're everybody's best friend during the weekend and night. So, so you do that, you do a good job, and people want to use you. Why wouldn't they want to use you to take care of their patients? So there aren't a lot of times there's a surgical medical kind of differences that you see in academics. That doesn't really exist on the community side. People are happy for the help. They're happy to work together. So generally that shouldn't be something where if it's somebody says it's an open unit, that shouldn't turn you off. So like I said, they already have multiple consultants, strong existing referral base. Sorry, just have to keep clicking. The staffing pattern that's the best out there that we know is 24 hours a day, 7 days a week. That's the best model of in terms of patient care. It does require a lot of FTEs. FTE is full-time equivalents, hired positions to cover that. At least you have to have at least 4 to 5 full-time docs to cover that with single coverage, one doc during the day, one doc at night. So it's the best one out there. It's getting more and more common. Probably about 50% of the community hospitals have it. Most academic centers have it that way. But you'll probably come across that fairly commonly. The other pattern you'll come across is a 12-hour day shift where the intensivists are on site during the day when most of the patient activity occurs. You can usually do that with the 2 to 3 docs for single coverage. Do have to have somebody in there at night. So usually there's a house doc, a moonlighter, a surgical house officer. There's some prime mover that's in-house, but it's not the intensivist they're covering from home. That's fairly common out there on the community side. It happens on the academic side. Usually they're using fellows in-house and the attendings are at home. Although more and more even academic programs are going to 24/7 attending coverage. One of the other things you may come across is people want to start a program and they want you to come in as a director and piece the program together with the docs they already have there. That is only minimally effective. You have one FTE. It's low cost to run, but it's also a horrible situation. If anybody offers you this, you should basically run away screaming. It never works the first time. They'll wheel out buckets of money for you to get you to come, but basically you're trying to build a program with a bunch of people that you don't have any leverage over. The hospital just wants to come in and be able to say they have a program and want you to kind of organize these people. It almost never works. So if you get into that situation, it usually means the hospital isn't quite ready to have a really organized critical care program. So I would stay away from that. Typically, what you should be looking for on a day shift is for staffing wise, about 1.5 intensivists for the first 12 to 15 ICU beds. And that usually means like a long shift, short shift. For every 12 beds above that, you should be adding another intensivist. So you can there are some programs where bed numbers will be a lot higher, but you're not going to be able to do the kind of job you want. So you should be looking for, on the average, about one doc for every 12 patients during the day shift that's staffed. If they're asking you to see 20, 25, 30 patients as you're the only doc, you're not going to be able to kind of do the kind of job you want. You're going to be just running from patient to patient. So that's kind of the ratio that you should really be looking for. At night, usually one intensivist can cover about 25 to 30 beds. We'll usually add APPs after that. You can sometimes have a late shift to help with some of the evening work from your daytime people. But that's about nighttime, what you should have in there. We have about 40 ICU beds here at the main hospital that I work at. Nighttime, we have one doc and one APP on. Yeah, okay, and so next we're going to talk about the contract itself. So we just talked about the kind of hospital and program you're going to come across, and those numbers go for academic as well as community hospitals. You shouldn't really be covering a lot more than that. Sometimes you can do a little bit more with fellows and whatnot, but 12 to 15 beds per attending is about what you want to have. So these are all the components of the contract that you need to be aware of. You may not need to do much with each one of them, but you should be aware of. So we'll talk about each of those in detail. So what are the duties that you're going to be expected to do? There's going to be a certain amount of clinical duties. You may have non-clinical duties. You may have teaching. You may have research that you're expected to do. Each place will be a little bit different. You may have administrative duties. You may need to manage office staff. You may need to manage residency or fellow programs or other parts of the program. So all that should be outlined, what the expectations of your duties are for that job. Your time commitment should also be laid out. How many hours per week, per month, per year are you expected to work? Do those hours count the same as your clinical hours versus the hours you're spending for non-clinical duties? What's your credit and compensation for non-clinical duties? And what about call? How does that count? So what we see out there and what you should be looking for is the average number of hours per week of clinical time is about 45 to 50 on the average that we're seeing there. Now that may change according to the pattern of the schedule. Like we'll have this 1 week where we do 7 days. So that'll be a 70-hour week. And then other weeks when we may only do one night or whatever. But you should be looking on the average over whatever period of time the schedule block runs. The average should be probably between 40 and 50 hours a week of clinical time. When you get above 50 hours, it doesn't sound too bad, especially for what you guys are doing now as fellows. But when you get above that for long periods of time, it's hard to do. So that's what you should be looking at. No more than 4 nights in a month. Again, as you get older, as you have families and kids and things, the number of nights away really takes its toll. So on the average, you should not be doing more than 4 nights a month and no more than one in every third weekend. I would say typically I schedule all my people for no more than one in every fourth weekend. Again, with families and you have young kids and things like that, over a period of time, that gets very difficult to do. So that's kind of what you should be looking at in terms of workload for what you'll be expected to do on the clinical side. Your salary components, you're going to have a base salary. That's going to be your base salary of $300,000. That's your base salary. And that can be determined by a number of different ways. The MGMA has the most data out there. It's voluntary. You voluntarily report your data from your program, from your practice. So that has it. But usually what you'll kind of look around is what the local area salaries are. That's where you'll see where most of the people will look to be, what the local environment is. You need to understand what what the terms of the contract are. How long is that base guaranteed? For how long is it guaranteed? And so what I do with the base salary that I make for people is none of that is at risk. That base salary, and that's what you're going to take home every 2 weeks, every month, however you get paid. And so you want that to be the same. So when I develop programs, the base salary is not at risk. We'll talk about bonuses in a little bit, and that's the money that's at risk. So your base salary should never really be dependent on how much you bill or things like that. You should look for a place that is guaranteeing this is your base salary, and then the rest of the money you get is going to be based on bonuses, and there are a number of different ways to bonus people. You should be looking if there are regular increments. Do you have cost of living increments, seniority increments? Not every place has that. Again, some pay, like we have in some of our programs, a 3% cost of living increment, but cost of living is really meant for lower paid individuals, so that may not be there, but there should be some expectation of where your salary is going to go over a certain period of time. So again, I said the baseline salary, whatever it is, should be a guaranteed amount. Now we put a citizenship component in there. That's between 5 and 10% of your salary that I have access to as the director if you don't perform the basic duties of what you're expected to do. You don't do your charts, you don't bill, you miss shifts, things of that. That's kind of my stick for what I can take the next 6 months. I can lower your salary by between 5 and 10%. I have never had to use that. Basically, if I get to that point, I've already been having long discussions with somebody, and we know whether this is going to be something that moves forward or not. So that you may see that in there. Again, I have never had to use that. And again, are there seniority increments in what you're doing? I usually have incentive-based components to the contract, and that's usually 10 to 20% of baseline, or even a little bit more. So if you're at $300,000 base salary, I'll usually add another $30,000 to $60,000 worth of available bonuses to you. There are a number. We'll talk about the way that some of the bonuses are structured. There's a component of productivity, for quality. How you want to know everything when you're going into a job. How are your bonuses? How are the bonuses structured? How are they paid? You also want to know, do people get a lot? You can have a bonus package that looks great, but if nobody's getting the bonus package, then there's something wrong. We usually look to see people getting about on the average, between 50 and 75% of all the available bonuses there. If they're getting less than that, then that bonus isn't really as much as it sounds like. Um, uh, and then you're also going to talk about benefits, vacation. Are they part of the salary package? How does that work? If you're going to be a director, usually on top of the base, I'll give you about a $25,000 additional stipend for directorship. For small programs, I'll usually do about 50,000. For bigger programs, I'll do 25% of the salary. That's in addition. So, and that doesn't count the bonuses. So, say you're getting $300,000, and I'm going to give you 25%. What's that, like $75,000 directorship stipend, and that's usually added as a line item uh, to the salary. Um, I'll also give you decreased clinical hours. I use for small programs. I'll take your clinical time down to 75%. That's usually for programs with up to 10 or so full-time docs. Above that, I'll start getting closer to 50, give you 50% administrative time and 50% clinical. So that's what you should be looking at as a director if you're going in as a director. There may be other incentives and bonuses that you're eligible for, but at least as a base package, that's what you should be looking for. So incentive plans. Incentive plans are usually 10 to 20% of the baseline. It's a good way for me to add salary dollars that are at risk, that the hospital agrees, hey, yeah, if you're more productive, I'm getting more money, you should get more money too. So I have three different parts of incentive, three different bonus plans that I use. I use a quality bonus, a productivity bonus, and a discretionary bonus. The quality is a group bonus, productivity and discretionary are individual, and we'll talk about these. So the quality incentive plan, I have a set amount of what the award's going to be. I pick parameters that are within the doc's control. CAUTI versus, so there are a lot of components to CAUTI. I usually pick full utilization ratio. So that that's something that the doc, that's just the number of fully days in the unit. That's something the doc has direct control of. There's a lot of components that go into Foley. So I try and pick things that um, that uh, that really are in the doc's control. It's usually a group award, so since not one person is responsible for every infection or whatever it may be, so everybody in the group gets the same quality award. So that's whatever we set the parameters, and when you hit them, everybody gets the same. So you all work together for the same for the same oops, sorry. Um, sorry. You all work the same for the same quality. I prorated. You have to be there at least. I do it on every 6 months. You have to be there at least 3 months out of the 6 to qualify for the quality bonus. I usually give APPs the same quality bonus as the MDs. So that's usually the same. I usually pay it semi-annually. And these are targets that I review with administration. It needs to be something that's important for the hospital as well as important for the group. So you kind of talk about these and annually you review them and see if they still make sense. For the productivity plan, again, set amount of reward. I pick reasonable targets. I usually pick the 50 percentile target of the MGMA, which has these things laid out by locality and specialty. This is an individual award. Everybody's productivity is their own bonus. So that's not a group bonus. Everybody makes their own based on what they're doing. I prorate that if somebody's out for a while, they'll have that threshold prorated. I do something different with the APPs and the MDs. We used to have it so that each of the APPs and the MDs had their that's nurse practitioners and physician assistants APPs. Each of them had their own productivity bonus. We usually pair an APP up with a doc for whatever service they're covering or whatever service area they're covering. What happened was there was one of arguments of people arguing about who was going to bill what, which wasn't good for anybody. So what I do for my APPs now is they tend to see less patients, and we only get reimbursed 85% of what is billed by an APP. So what I'll usually do is give the APPs 50% of the average award that all the docs get. So if one doc gets 10,000 and another doc gets zero, the APPs will get 50%. It works nicely because for the APPs, it's a win-win if the docs bill more. So it helps the APPs in wanting to support the docs to be able to work more efficiently and effectively. Again, we review these targets on an annual basis. I have a discretionary pool. I have a pool of money. It's usually around $100,000 that I can use to award people for things that are non-clinical that they're doing or they're not getting stipends for. I usually have a point system, and so I think this is an example of one doc, and we do this on an annual basis. If they served on the Patient Safety Quality Council, it's 2 points. COVID and supervision oversight, this person got 5 points. Ethics committee, 2 points. So there are a number of different things, and you could structure this however you want in terms of people running programs, mentoring, whatever they're doing. You give them a certain amount of money. I take all the points for everybody in the program, and I divide that $100,000 by the total number of points, and that's what everybody gets paid. So this doc had 31 points, and they got a $8,500 bonus. Say this is the same for docs and APPs. That's all the same. Other things that you should talk about. What happens if you're doing stuff outside of your job? Are you allowed to moonlight? If you moonlight, does that get paid directly to you, or does it go to the company? Research, if you're getting grants, how are those counted? If you're doing expert testimony, consulting work, things like that, do you get the money for that, or does it go to the group? Same thing for honoraria, for speaking honoraria. And what about inventions? If you invent something, who is legally, who has ownership of that? Typically, if you've done it while you're at work and it's related to work, then the company, the department, whatever, is going to want a significant percentage of that. So that should be, that doesn't come up very often, obviously, but these are some things that you should be thinking about. Is there a signing bonus? Do you get a bonus when you sign on? Here, I give a $10,000 sign-on bonus. If you don't ask me for it, I'm not going to give it to you. Doesn't hurt. It never hurts to ask. You should not be. I can't tell you how many times I interview people, and by the end of the interview, people have not even asked me about the salary. So I usually wind up saying, "Do you want to know what I'm gonna be paying you?" It's okay to ask about salary. We expect you to ask about salary. You want to get paid to work and whatnot. So I expect you to ask what the salary is. If we're $20,000 off in salary, then we can probably find some middle ground. If we're $100,000 off in salary, it's probably not going to be a good fit, and then we really shouldn't be wasting each other's time. So you should at least have general expectations of what your salary is, what your salary expectations are, what's your break point for where that's just not going to work for me. So it's okay to do that. It's okay to ask about that. It's okay to have salary expectations of what you need. And salaries are going to be different from region to region. You can go to Mississippi and make a boatload of money. You can't do that in Hawaii. You can't necessarily do that in New York City. Desirable places tend to have lower salaries. You can judge what's going to work right for you and your life. So you should at least know what your salary range is, and have an honest conversation about that. Like I said, if we're so far off that we're never going to meet, and that's fine. That's okay. Then we know this is not a good fit, and we'll both move on to other opportunities. So it's okay to ask for a signing bonus. It's okay to ask for moving expenses. If they can't do it, they can't do it, and they'll tell you. But a lot of times, if you don't ask, people aren't going to just offer it up. So it's always okay to ask. And and again, like I said, you kind of decide what hill you're going to die on. Is this really? There was one doc, and the most I could come up, because we're part of the system, so I had limitations. So the most I can come up was with a $15,000 balance between the sign-on bonus and the moving expenses. And this person wanted $18,000, and I just couldn't do it, and they wound up not taking the job, which was a job that would have been a good fit. So again, think about what makes sense. Is it really worth not getting a job for a few $1,000s on a two or $300,000 salary? So don't get yourself backed into a corner that you don't necessarily want to be in. When you're looking at your contract, the term is usually 1 to 2 years with an automatic renewal. That's normal. You don't get contracts longer than that. Most contracts have a 90-day termination with or without cause. That means you could just say, you know what, we're not getting along. This isn't a good fit. We're going to terminate the contract on either side. It's usually about between 90 days and 6 months with a termination clause in there, and that's standard in most contracts. Immediate termination can happen if you're caught stealing, you're caught fraudulently billing, any of those things. Then most of those will be spelled out that will be escorted out, and the contract is done at that time. Those are usually spelled out, and they have to be pretty egregious things, but that should be in the contract that you see. What about vacation time? Vacation time is typically 4 to 6 weeks a year, not including CME time. If they give it, your vacation can be awarded as weeks. It could be accrued as hours per month. There are usually rules for the vacation time that should be clearly outlined. How much can be taken at once? Like we have a rule, you can't take more than 2 weeks without getting approval from the department chair, just because it causes such havoc with the schedule. No, we give it when we can. What happens to your vacation time if it's not used? Does it roll over to the next year? Do you stop accruing? Is there a cap? Most of the places are going to have a cap that you can only accrue so much, and then you stop accruing it. So that should be outlined in the contract as well. Malpractice. Typically, malpractice is 1 million, 3 million, which means 1 million, 1 million per incident, 3 million total for the year. That is a lot of malpractice coverage. Some people want 2 million, 5 million. They've asked for. All that does is make you a bigger target. It is very rare to have a claim above that. So that's more than enough malpractice insurance. There are two types of malpractice insurance: claims made, which means the policy covers events while the policy is in place. And the second is occurrence, which covers all the incidents which occurred during the policy period, regardless of when they're reported. So if you're in a different job and you get sued for something that happened 10 years ago, if you have an occurrence policy, that original carrier will cover that. Occurrence policies don't exist. You're never going to get them. All policies out there are basically claims made policies. So whenever you get sued, regardless of when the incident happened, the company that you have will be the one who covers you. Now, the problem is they don't really want to be responsible for things that you did before you joined them. So what they will typically require you to have is what's called tail insurance. And you only have to have tail with claims made, but again, that's all that's out there. So tail coverage means you can buy tail coverage. Basically, what it does, it covers you for 3 years. The statute of limitations on medical malpractice is 3 years. You can't get sued for anything that happened more than 3 years ago. So this tail coverage will cover you for anything that happened in the prior 3 years. So any new job that you're coming into will want you to have tail insurance, so that they're not liable for things that you did before you even got there. And that can be a problem. Tail insurance, one thing coming out of fellowship, it's nice because tail is always covered. But if you're going from job to job, tail insurance is expensive. It costs about $30,000 to $40,000 for an intensivist. And that's something that you will have to pay out of your pocket. So it is extremely important when you are taking a new job that you determine whether or not tail insurance is included in the job. When you come and you work for Hopkins, we cover your tail insurance when you leave. That's part of the contract. Most small practices, small programs will not be able to do that. So you need to think about that, because when you leave that group, if you leave that group, then you're going to be saddled with a $30,000 to $40,000 bill that you just have to pay. So it is very important to understand the kind of malpractice coverage you have. There are a couple of different things: prior acts versus tail. It's all the same, but you should really be looking for the company. Now, we did it in when I owned a private practice. We basically did it so that the first 3 years we didn't cover tail. Between 3 and 10 years, we covered 50% of the tail, and after that, we covered 75% of the tail. So you can have some progressive things like that also that are fair, and that can do it. So again, you need to find out very clearly whether or not there's going to be tail is included when you're joining a program. The other thing that comes up is non-compete covenants. Basically, non-competes mean you can't leave without a penalty. Those are really made more for outpatient practices because they don't want to, or places where you can steal patients. It's meant to protect the institutions against you stealing patients from them. It really is. That's really not an issue for critical care. I mean, we can't steal patients from. They come into the ICU and we don't see it. Now, some of you may do pulmonary and critical care, and there are some components. There were recently some states that were trying to enact a law to just disallow them altogether. That was struck down. So basically, you should negotiate to eliminate, if you're doing straight critical care, certainly, you should negotiate to eliminate or really narrow down the scope and duration of a non-compete. Usually, non-compete tells you that you can't practice in your field, whatever it may be, within a 10-mile radius for 2 years, or something along those lines. Those are the components that'll be in there. So again, you need one is very few places will try and go after you for non-compete. They're very hard to enforce, but there's still legal clauses and they're there. So if you can't get it out of your contract, then you should make sure that it's limited to your scope of practice. So you can't practice medicine anywhere, any kind of medicine for however long. Usually duration is between 1 and 2 years. It should never be any longer than that. Shorter if you can. And location. It should be a reasonable geographic area. You know, it shouldn't be 100 miles. Even in New York City, it shouldn't be 10 miles because there's 100 hospitals in 10 miles, because that will cause you to basically to have to move if it's if it's in the confines of your non-compete. So for the most part, and lawyers can be helpful there, for the most part, try and negotiate those non-compete covenants completely out. There are fewer and fewer of them around, but they still exist. But try and negotiate them out of the contract if you can. Sickness and personal disability are sick days in addition to vacation days. What happens to them if they're not used? What happens if you exceed your allowed sick days? Is there short-term disability included with the employees? And most large employers, there will be. Is disability a reason? How long can you be disabled before they say we're ending your contract? Is it 6 months? Is it a year? Is it 3 months? Those things should be in the contract so you understand if something happens to you. You want to understand what's going to happen to your income. Same again, disability. What kind of policy do you get reimbursed for the policy? How much time will the employee be covered by the group? Typically, the short-term disability, which is provided by the employer, is about 90 days, and that allows you to extend to buy your own policy with an extended waiting period till it kicks in. Disability insurance is extremely important for people to have, and it's often overlooked. Remember, if you die and you have life insurance, it's one and done, and you're gone. If you get disabled, you can have many years of not generating income. So especially if you have, family and kids and all of that, or responsibilities to other people, you should have some form of disability so that your income is protected if you should happen to get disabled. We all see the young people who have a horrible accident or sickness or whatever, and they're, they're out of work, or they're not going to be able to work for a long time. And that can, we saw it with COVID, right? That can happen to anybody. So that's something that everybody should have. And a lot of companies will, you may have to pay for it at a discount rate, but a lot of companies will have some option for long-term. Most of them will provide, bigger places will provide short-term disability. A lot of them will have an option for you to buy longer-term disability. What about if you die? What's going to happen? How long will health insurance be provided to your family if you die? Was there a compensation for your remaining sick time or vacation time? Are you entitled to your accounts receivable? Is the money that you've billed for the group but hasn't been collected on your behalf? Are you entitled to any portion of that that'll go to your family? So what are the things that happen if you die? How long will your family continue to get your benefits? There are other smaller things that are there. Medical benefits. People have, most companies will have medical benefits. Find out, how is it mandatory or optional? If you have a spouse that gets health insurance, do you have to still take it, or are you able to get a discount, or you get some of that money back because you're not taking it? Who pays it? Can you take it with you when you go somewhere? Is it family versus, a number of different things like you've all dealt with your health insurance, but you should find out some places are smaller groups will just give you a set amount of money a month and say, or go out and buy your own health insurance. We can't afford a group policy. Group policies are priced based on the age of the people in the group. So if you have a group with older people, it's going to be more expensive to get a group policy than it is to get your own individual policies. So in small groups, you'll usually have some leeway with that. In bigger institutions like academic institutions, that'll all be pretty fixed. Other thing we talked about a little bit, long-term disability insurance. Can you take that with you? Life insurance, term versus whole life. Is that life insurance portable? Can you take it with you? Can you take it with you when you go? All those things should be in the contract if they happen. And these are less important things than some of the things we talked about. Is there a retirement plan? Typically, we're seeing people matching up to about 15K a year. So how long do you have to work before that money becomes yours? Is there maternity and paternity policies? And how are they paid? Most places have a maternity policy. It's usually 4 to 6 weeks, sometimes longer. Now we're doing more and more with those paternity policies as well. So we give at Hopkins, we give 4 weeks of paternity leave we call bonding time to the fathers of the baby. So that again should be outlined there. What are the things that are available to you? Other benefits, CME, typically you're going to see about $1,500 to $5,000 a year that's available for CME, which is usually used for meetings and dues, not usually for durable goods. Like they don't usually let you buy computers with it or things like that, but there's usually something there. So you should find out about that. Again, how much time is allowed to, if you're going to be off for CME, how much time is allowed? How will they pay for everything? Do you have to use your vacation time when you take your CME benefit? What if you're presenting a topic or a paper? Do you still have to pay for this out of your CME money? If you don't use it, it can be accrued to the next year. So most practices will have, it's usually around $2,000 for CME expenses. That's usually meant for meetings and for dues. It usually doesn't cover a full meeting. So some places have more. Now we have 3,000 now. We're probably going to go up to 4,000 next year for everybody. And then other smaller benefits, dues, licenses, pagers, cell phone, journal subscriptions, automobile expenses if you're practicing in different locations. All those things you should be looking should be in there if they're available to you. If the partnerships are fewer and far between now, so if there is a partnership track, time to be eligible, is there a buy-in? How is that determined? What are the benefits of partnership? Do you get a buyout when you die? For critical care, that used to be these small private practices, and I've owned a couple of them over the years, were pretty common. Now that's few and far between. Really, almost all critical care, so at least straight critical care, is pretty much employed by either a larger group or a hospital. So these individual partnerships really don't exist that much. You may get them, you may come across one or two of them, and these are some of the questions that you should ask. And then you've done your contract, you got everything taken care of. So what do you do then? You need to make sure, again, most contracts are going to be very thin. And there are going to be some things within there that you need to negotiate and figure out what's important to you. And that's why it's important to at least understand something, because then you can get a lawyer and tell them to look at your whole 30-page contract, which 90% of it is just boilerplate stuff, and they'll charge you several $1,000s to do that. Or you can tell them, look, I've read this contract. I want you to help me with negotiation for tail coverage, and non-compete clauses, things. So as long as you get an idea of really what's important to you. So yeah, there's usually some negotiation room here between the two parties. So again, first decide, do I really want this job? And what are my break points where I say, yeah, that's just, if we can't do that, it's just not going to work for me. You should review your contract yearly or every time the contract is renewed, and make sure that it still meets your personal status. As you get older, you get married, you buy a house, you have kids, you're getting ready for retirement, your needs change, and your contract should grow with you. At 70 years old, you're going to be expected to be doing the same amount of clinical time as you were at 40 years old if you're in a practice for a long time. So you need to understand the contract, and the contract needs to grow with you. So you shouldn't just put it in a drawer and never look at it again. If there are any significant changes, then you should have it re-reviewed by a lawyer if you need to. So that's the basics of contract negotiation and what you guys should all be thinking about. Again, not every one of these components needs to be in every contract, and they won't all be in every contract. But again, this kind of gives you a menu of the things that you might see out there, and for you to kind of think, well, again, what's important for you as you kind of move forward in your career and start joining the attending world. So I think that's it. I left some time, a little time for questions if people have any.
Yeah. Hi, Dr. Rotello. I'm Sam Aqua. I'm the director of the medical ICU.
Yeah.
Unfortunately, Dr. Oropello and Dr. Liebner had to leave early
Yep, I know.
with some commitments. Yeah, so again, thank you very much. I think this was very important, for us, as clinicians, know how to negotiate. I'm sure we have a lot of questions. And I open up the floor. If anybody has any questions, please go ahead. I don't see anything in the chat yet.
And I put my contact information is there. If you guys, as you're getting soon you'll be starting to get your contracts. Feel free to reach out to me. I'm happy to answer any questions or whatnot you might have.
Yeah, and again, I like that you said that salary discussion should be part of the initial discussion. I think back in the day we thought it was a taboo topic,
Right,
the initial discussion. But
yeah.
I think I agree it's very important, just to know, where they're starting and what you can negotiate. So one thing I'm interested in a lot is these non-revenue generating activities. I see that in your presentation, you accounted for them a lot, but I think in different institutions it's very difficult to justify or to pay for, and I'm just wondering, where you get revenue to support, these quote unquote non-revenue generating activities.
So when I build programs, when I build a program, I usually add of total administrative time of about 0.05 FTE per doc per full-time employee. So if I have 10 full-time employees, I usually add around a half at 0.05 times 10, about a half an FTE in the contract, exclusive of the director time. So I may need some time for somebody to be my quality officer, things like that. So when I'm building a program for a hospital, for an institution, that'll usually be part of what I put in the build for the program, like saying, hey, the kids don't have all these docs doing just clinical time. There are things that have to happen. You want us on this many committees. You want us on that. You want us to help with protocol development, teaching. All those take time and take money, and I have to be able to compensate my guys for the time that they're doing. So some of it I'll do as give them a 0.1 FTE to run the fellowship program, for example. Then the other things that I'll use are my discretionary funds. Like I said, I have that pool of $100,000 that, based on the other things that people are doing, non-revenue generating, I have a way to reward them for that. So that gives me a little bit of leeway in terms of, being able to give people a few $1,000s here and there for running committees and things like that. And some stuff you're going to do for free, right? There's a lot of stuff we all do for free. So that's
That's
part
very
of it.
true.
And
Yeah.
as you get older, you do more and more for free too. And so that's all part of it. So you're not going to get paid for every little thing you do. But if there are things that are requiring a significant amount of your time, there should be some compensation in it or some way to bonus you for that.
Okay, thank you. Any other questions from the group? Okay, and all right, so I think that's let's say from Dr. Liang, sometimes when you negotiate, you may be told something along the lines as if I do this for, let's see, sorry.
Yeah. Then if I do this for you, then I have to do it for everyone. Yeah, and that's true. I can't give, like that person I was talking about with the sign-on bonus. I have a little bit of leeway, but I can't give them that much more of a sign-on bonus than I've given them. Bottom line, everybody talks to each other. Okay, so you do something for one, no matter what you say, that everybody's going to know very quickly. So we do have to be careful. So I'll have some leeway, but some of the things that, I can't go so outside the box for one person unless they're bringing something very special to the table, where I can validate that I'm going to compensate more because you have this special skill, or I'm going to have you run a certain program or be an associate director, things like that. So I think it depends what you're asking. If it's just salary, there's going to be guardrails for how much salary, and there's usually probably about $10,000 to $20,000 leeway in salary. When I negotiate, I can start somebody a little higher. Sometimes you'll have a program where your first or second year you get $10,000 or $15,000 less, and then you go up. Sometimes I can shorten that time frame. I can say, well, I'll start you as if it was your third year here. So usually within the $10,000 to $20,000 leeway with salary. Probably not a lot more than that you're going to get. We don't have that big discrepancies in what we can offer. How are your fully staffed nights of no more than 3 nights? I use some moonlighters and part-time people. So I'll staff with a number of full-time people, but then I'm in an area where I do have moonlighters. But most places you can find some moonlighters. Some people can use fellows or residents from other programs. So I try and have a moonlighter every Friday and Saturday night, and sometimes a little bit more than that. So I usually do that with so not all my attending positions are single people. So I may have like 2 attendings worth of positions that I fill with part-time people. So that I have that flexibility on the weekends and on nights, so that I'm not killing my people. So that works. That's how I kind of make that work a little bit better. And in some places you don't have that leeway, but you can usually find some people.
Yeah, okay. I guess the last question from my standpoint is, as the operating director, are you expected to be budget neutral? Means that your physicians supposed to pay for themselves, or does the hospital
No.
recognize us as a quality improvement? Because I see us as a quality improvement team, right? Okay, in terms of our
So
stay.
usually, critical care or hospitals are never meant to be budget neutral. We're never going to make when you get into all the fringe. On top of every salary, there's about 30% fringe benefits that are paid, and all. So you're never expected to do. So what we look at is we look at the amount of support per FTE. So usually that's for an intensivist, the expectation is usually about $100,000 to $150,000 per FTE that the hospital expects to support. So in one of my programs, I have 10 full-time people. So that program costs the hospital about $1.5 million. And they understand that, and they expect that there are a lot of benefits that hospitals get from having a critical care program. So I don't think there are any hospitals out there that really expect you to be cost neutral. Private practice is a little bit different because but those private practices have usually negotiated a contract with the hospital. But usually about $100,000 to $150,000 per full-time person is what the expectation should be that the hospital has to kick in.
Excellent. Any other final questions, anybody?
Yeah, I have a question.
Sure.
This is Umesh Gedwani. I'm the director of the cardiac ICU. You said that, sometimes hospital get benefits. What kind of benefits do you think the hospital gets? Are you talking about leapfrog criteria or something else?
Well, some of that, but more about the programs that they can do. If they didn't have intensivists, they couldn't have a cardiac surgical program. They probably couldn't have a neurosurgical program. They couldn't take these sicker patients that they would normally have. So it's kind of, when you look at the data out there, it's for every dollar a hospital spends on an intensivist program, they get about $3 to $5 back in revenue from other sources. So they're able to provide a lot more patient care alternatives than they'd be able to do without. And there are some things you get from leapfrog and things like that. Those are usually above and beyond, but just having a good quality ICU program draws patients. You could support more complex care. It draws additional patients into your system, into your hospital.
Right. So the critical care service then is an enabler for the hospital to expand its range of offerings and complexity of care.
Absolutely. That's the biggest benefit of a critical care service.
And to provide the resiliency that one requires when you provide complex care, yeah?
Yep, absolutely. Yep, that's the main driver of why hospitals want critical care.
Great. Thank you so much for such a wonderful talk.
Yeah.
Thank you.
Okay. And then, if people want, just feel free to reach out. I'm happy to answer any questions.
All right. Thanks again.
All right. Thanks.
Thank you,
Good
Dr.
seeing
Rotello.
everybody.
Thanks.
All right.
Bye.